Placing a central line, the basics. In this lecture, we will discuss the basics of placing a central line with ultrasound guidance, in this case, the internal jugular. This is a lecture part of the lectures from point of care ultrasound for the residency of Danbury Hospital. This is Christian Spanish Schmidt, MD and FACP. So central lines are common procedures in medicine, very useful for monitoring, blood sampling, resuscitation, parenteral nutrition infusion. It's not a procedure without complications, very important. Complications can be greatly avoided by the use of a sterile technique and the ultrasound. There are many indications, but not only: central venous pressure monitoring, volume resuscitation, cardiac arrest, lack of peripheral access, infusion of hyperalimentation, infusion of hypertonic solutions as well as pressors, placing of transvenous pacemaker, cardiac catheterization, pulmonary angiography, and hemodynamics, as well as hemodialysis or plasmapheresis. There are more indications. There are some relative contraindications such as bleeding disorders. If patient has bleeding disorders, anticoagulation or thrombolytic use, let somebody with significant experience do the procedure. Combative patients, distorted anatomy, this is greatly improved with the use of ultrasound, cellulitis, burns, and severe dermatitis on the site of the venopuncture, and vasculitis. Complications might be vascular infections and miscellaneous. Some of the vascular complications are air embolus, arterial puncture, arteriovenous fistula, hematoma, and thrombosis. Some infectious complications are like line-associated infections, cellulitis, endocarditis, and bacteremia. Miscellaneous complications include dysrhythmias, catheter knotting or malposition, nerve injury, pneumothorax, hemothorax, hydrothorax, and mediastinal injury. And when you are using an inguinal approach for a femoral, it's very important to remember bowel and bladder perforation. Here, one of the complications: this patient had a subclavian line that went through the IJ. You can see the line going up. There's another patient that we had who had an IJ in the right jugular and an magnetic resonance that demonstrates the lack of flow on the right IJ. Complications are greatly improved with the ultrasound, and you can see the internal jugular ultrasound guided has the least amount of complications. Some other complications, for example, the subclavian catheter in the white arrow has been complicated with pneumothorax. You can see the pneumothorax clearly in the red line. This can also occur in intrajugular approach, and it's greatly improved with the use of ultrasound. The use of central line bundle is obligatory in the placement of central line. These bundles contain drapes, ultrasound probe covers, sterile coats, masks, head caps, and can be found in the central line placement cards. Also, you can find all the necessary equipment in the surgical card that we discussed in the other talk. So, no infections. Here, sometimes when you want to place a peripheral line or an A line, you can use a tegaderm, a sterile tegaderm over the probe as a way to sterilize it. However, in the central line cards and surgical cards, you will find full probe covers and sterile gel in the hospital. But if you don't have the luxury of having a full probe cover and you're going to do a peripheral line or an A line, you may use this type of way to sterilize your probe. This is part of the equipment. This is the catheter you will find in the central line kit. The catheter 1 at the end will be placed over the wire you see in 2. This technique is called catheter over the wire or Seldinger technique and is one of the most common techniques using in placing tubes. It is important to point here that all the catheters of this triple lumen are named, and you can see the distal catheter. There is a proximal, a distal, and the proximal catheter usually is brown mostly and is the shorter. And this is where the wire will appear when you are feeding the catheter through the wire. These are other parts of the kit. One is the main needle or trocar that you will use to explore and cannulate the vein, and the wire will fit inside the needle. There is a scalpel that is used to puncture the skin only in order to pass a dilator. 4, you see the dilator, and this is to dilate the skin only and not the vessel. Avoid placing the dilator through the vessel. The vessel will dilate with the catheter alone. Also, you will find a clip to fix the catheter, 5 and 6, and a syringe for lidocaine. Place all your sharp equipment on the container named as 10. You can see there is a sponge there. You can just put all the needles there, and you will have some 4x4s in 11. In the carts, you will find more 4x4s if you need them. So no infections, gloving and draping is very important step in placing a line. There are multiple videos in how to glove and drape. New England Journal of Medicine has. Always remove all jewelry from your hands and watches too. Place your gloves as noted in this figure without putting your fingers out of your sterile coat to maintain germs out of the sterile field. So before you put your fingers out, you should have cover your sterile coat with the glove. So the probe that you will use is the linear array probe, and as you always can see and we discussed before, you can have a longitudinal view of the vessel like we see in the first picture, or an axial cut of the vessel when you attempt to cannulate. I usually use the axial or transverse cut. Very important, no infections. The use of sterile chloroprep is needed and is available in the central venous kit and the catheter bundle as well as in the surgical cart. Clean the surfaces thoroughly. To release the cleaning fluid, you need to break the reservoir as noted in this figure. There is a video also how to break this in procedural medicine. No infections. The sterile use or one use only ultrasonographic gel should be used all the time when prepping a patient. Here we see how the probe cover is being filled with sterile gel before placing the probe. Once the sterile gel has been placed inside the probe cover, a helper who is non-sterile will place the probe in the cover. The cover has small pulls that can be used to slide the probe cover through the wire of the probe. Very important, look how this is illustrated. To maintain the gel inside the tip of the probe cover and the probe cover and the probe, there are 2 elastic bands that should be placed over the probe cover. Try to squeeze any air bubble in between the probe and the plastic cover to avoid artifacts. So, placing the line. There are anatomical landmarks where you place the catheter. Avoid placing a catheter through the sternocleidomastoid muscle. Try to use the space between the clavicular and sternal sheaths of the muscle. The objective of the following slides is to demonstrate the Seldinger technique. In here, the operator is placing the needle. Always apply negative pressure while you are attempting to cannulate the IJ. This is the correct way to feed the wire. As you notice, there is a kink at the tip of the wire. This is to avoid vascular damage. Withdraw the wire inside the wire receptacle, and once the tip is in and the vein is cannulated, feed gently the wire inside the vein. You should find minimal, if any, resistance. If there is resistance, you can push gently back and forth, changing the direction of the wire. Once you have placed the wire, you can withdraw the needle and make a small cut of about 1 millimeter through the skin, only to pass the dilator. The dilator can then be passed through the wire to dilate the skin only. The dilator is not intended to dilate the vessel. Very important, do not pass the whole dilator. The dilator again is for the skin and not the vessel. Be advised that you should have always control of the wire with your hands. The wire should never be left unattended. Again, the wire should never be left unattended. So placing the line. This is how the needle enters the vessel, and then the wire is passed. Again, no resistance, if should any, should be felt. If you feel any resistance and you know that you are inside the vessel, you may change the position of the wire and try again. After dilating the skin and withdrawing the dilator, you can pass the distal part of the catheter through the wire. Always have control of the wire and never pass a catheter if one of your hands is not on control of the wire. So when you are passing at the beginning the catheter, you should have control of the wire, and once the wire appears in the distal portion of the catheter, you should again grab it. There are many cases that this wire end up inside the vessels of the patient, and then you will become famous or infamous with the vascular surgeons and the IRs, who are the ones that will take the wire away. So remember, always control of the wire. So here you see the physician is placing or advancing the wire and having control, is advancing the wire through the catheter. So here is very important. You are not putting the catheter in, but advancing the wire in through the catheter. The catheter is already inside the vein. Once you have the catheter out, then you take the catheter and then you can start advancing the catheter inside the jugular or the vein that you selected for the patient. Remember, when you are going to cannulate with ultrasound, there are many planes that you can use. Play with the planes of the ultrasound to understand the anatomy of the vessel. Look for thrombus, look for ectasia, look for anything that will make this vessel not a good candidate for cannulation. So here we see how the ultrasound helps to visualize the vessel and the needle. Please see how the operator used the dexterous hand to operate the needle and the non-dexterous hand to operate the ultrasound. In both instances, you should be able to see the needle. First, we have the out of plane or transverse approach. In the second one, you have the long axis or longitudinal approach, and you can see the needle tip in both stanzas. Here, a transverse view of the internal jugular in 1. The carotid is also viewed here in 2. This patient has been placed in Trendelenburg position, and that's why you see an IJ that is larger than the IC. So the IJ here is large and is very important. You need to put the patient in Trendelenburg position, unless of course the patient is volume overload and you already have a very dilated vein. You can avoid that, but anyway, Trendelenburg position also will help you to avoid air embolism. So it's very important to keep the patient in Trendelenburg while you are doing this. Here, position, position, position. I found this image in the web always, and I want to point at the operator. Always place your patient in a comfortable position for you, where you can see here, for what you can see here, the operator will need to bend in order to cannulate the IJ. If you have, for bad luck, a difficult cannulation, you're going to be in that position for a long time. This patient is not in Trendelenburg. It's draped. It's good that the operator can see the ultrasound. However, the position is really awkward and it's not advisable for you to be like that. So remember, position, position, position. Sometimes you can feel mild resistance when cannulating the IJ and subclavian, and this is because of valves presence in both veins. So just be mindful of this, advance the wire careful, and change the position of the wire may overcome this, as long as you know you are inside the vessel. And how you know? With your ultrasound. So find a complication here. Well, you can see that this catheter is bent and is going into the azygos, this is a complication. The catheter is too far away, should have been placed just up to the trachea of the carina. So that's about 1 centimeter above the carina or around the carina. Sometimes the wire will not come back from a needle or a dilator. This can be secondary to kinking and happens sometimes. An experienced operator will withdraw all the wire and the dilator, the catheter or needle, and everything together to avoid leaving a piece of the wire inside the vessel. So be mindful of that. If your wire is not coming out, if you have problems to take the wire out, take everything out with you, and you will most likely overcome this type of problems. The dilator, as I said, is to dilate the skin and subcutaneous tissue, not to dilate the vessel. This can lead to complications, for example, injury of the vessel, and I have seen it sometimes. So complications, right tunnel catheter is inside which was not fully removed from subcutaneous tunnel, but was removed from the vein. Angiography, catheter passed through femoral vein from doing venography. Here, other complications. Sometimes you can injure the vessel, and in this case, in angiography, the catheter ended up in the pleura, and we have widening of the right hemithorax due to hemopneumothorax. So the patient needed a chest tube. So remember, there are complications for this. This can be avoided with the ultrasound. And here, a view of the vessels. Look, here we have the IJ. The IJ dilates and the IC or common artery, it's not dilated. So internal jugular artery increases with Valsalva, and the IJ basically maintains its shape. Also, when you press the vein, then the vein collapses. So that's a good indicator. I have seen some patients with pulmonary hypertension where the vein does not collapse, but most of the vein collapses. So here we see the operator going back and forth, checking that the vein doesn't have any problem and is easy. You can see also the sheets up of the sternocleido. Here we see a Doppler. We can see the pulsation of the carotid, the internal jugular, and the the flow of the IJ. So this is very important. And here the vein, look how it collapses with pressure. The artery does not collapse. The vein collapses with pressure and the artery does not collapse. And this is a very good indicator that you have the vein. Go for the vein. On top we see a little bit of muscular sheet, and of course the subcutaneous tissue. Please remember this when you are doing the real patient. This doesn't happen quite well in the simulation lab. By the way, what we see in the IJ is reverberation. Here we have a femoral artery and a femoral vein. You can see the flow of the artery and the vein. And then we have a different angle of the femoral artery and a femoral vein, mainly to show that how different appear the vessels in different axes when you are changing the axis of your probe. Remember, the color also will be red if the flow is going towards the probe, and blue if the flow is going away of the probe. So it will really matter the position of the probe rather than if it is arterial or a vein. So here we see a catheter inside the vein. You see the the catheter, yes. Here we see the guide wire. And the verification of a well-placed line, there are many ways. You can do an arterial blood gas and check what is the oxygen, the PaO2 there. You can see also if they're connected to an arterial monitor. And of course, be sure that you put the catheter with the ultrasound and take a picture of that. Remember, there are complications, and here we can see a guide wire that was not maintained under strict control and ended up in the inferior vena cava. This guide wire was removed by interventional radiology after a laborious procedure. So remember to keep your hands on the wire, very important. Do not stop keeping your hands on the wire. Verification of a well-placed line. This is a jugular that went through the subclavian vein. So this is a wrong placement. This line needs to be removed. Remember one thing. You always can pull the line, but once you insert it and you took all the drapes out, you cannot push in a line. Pushing in a line is a very common cause for infection. So you can always pull a line and replace it, let's say, but you cannot push a line, and it's definitely discouraged unless you don't have any other option. Here, a well inserted line about 1 centimeter above the carina or around the carina, and this is an IJ. Thank you. like the video and subscribe, and you are going to have more videos soon.